Hello and welcome to Expert Perspectives on the U.S. focus on myeloproliferative neoplasms and myelodysplastic syndrome. We are here in beautiful Alexandria, Virginia. My name is Srđan Verstovšek. I'm a professor in the leukemia department at MD Anderson Cancer Center in Houston, Texas. I'm joined here with my friends and colleagues, Dr. Professor Elizabeth Hexner and Dr. Professor Guillermo Garcia Manero. Very nice of you to join me here. We just finished the 2 days of very nice discussions and presentation about myeloproliferative neoplasms and myelodysplastic syndrome in 4 sessions. The first session was on biology of these diseases, then the second was on myelofibrosis, next one was on myelodysplastic syndrome, and the last one on polycythemia vera and essential thrombocythemia, which we will discuss this today. Elizabeth, in the first session on the biology of the disease, we start off with a rather provocative topic on the familiar inheritance, if there is any, of these diseases, MPNs and MDSs.
Yeah.
And you did, in fact, presented this for us. Can you summarize the main message of your talk?
Yeah, first of all, I guess I would say it's a very exciting time in this group of disorders, and really honing in on predisposition syndromes, and I think we're really just at the beginning. I think from a practical standpoint, the take-home message is really to just have a really high index of suspicion when you're looking at younger patients with myelodysplastic syndromes. We really think of it as a disease of the elderly, and if you're seeing a younger patient, and that's really about age 50 or younger, to start thinking about whether there might be some familial predisposition and that this actually might have some clinical consequences in terms of your treatment and treatment response. So I think that's one important one. There have been more than 5 syndromes identified within the last 5 years. There are over 20 syndromes classified, and that probably only covers about 30% of patients with these predisposition syndromes. So I think it's a rapidly changing area, and one that is just important to recognize. And probably Fanconi anemia, dyskeratosis congenita are the 2 major ones that would have major clinical implications in terms of treatment, particularly as you're thinking about allogeneic stem cell transplant. So I think just having a high index of suspicion is probably the most important thing from a practical perspective.
And the title of your talk was actually, Was I Born With This?, which is a rather nice title to elicit a reaction from the public. And it seems to me that your answer is, if you are younger and there are genetic abnormalities in your screen, which we do quite often these days, that there is a good reason to look beyond just your testing and look at the family members if it's necessary.
And so certainly, I think that most mutations that we're typically identifying are acquired mutations. But I think getting a detailed family history is kind of an old-fashioned idea, but it's very important. And I think that our patients are also very concerned about what the implications are for their own family members when they have this group of disorders. So, yeah.
Now, Guillermo, in myelodysplastic syndrome, Dr. Maciejewski gave us an excellent summary of genetic and epigenetic reasons for myelodysplastic syndrome to happen. It seems so complicated these days. There is the whole slew of mutations that happen over time, epigenetic abnormalities. We don't know which one is the first one, the second one, how we dissect it, and what does it matter actually when we come to therapeutic potential of different drugs?
Yeah, this is very interesting, and it goes a little bit into what Elizabeth was saying. So last year, well actually this year, at the beginning of the year, there were 2 papers published that demonstrated that if you look at aging population, quote unquote, healthy individuals will carry in their blood mutations on genes that we know are prevalent in myelodysplastic syndrome, and these individuals will be at a higher risk of developing myelodysplastic syndrome or other disorders. So I don't think that we understand what it means. I can tell you that we have not looked at this data because this analysis that they did in those 2 papers in New England Journal, they went, one of them at least is the one I'm more familiar, they went to Iceland, to one of these data sets, and they went back. But I can tell you that in my practice, I see people like this, that they come, they have some very, very minor cytopenia, you don't even know why they are referring the patient to you, you do the bone marrow, there is no dysplasia, there is no issue, and then you find a mutation on TET2 or one of these genes. And then the question is, do they have a prodrome? How do you follow? Do you intervene? I think at this point we don't really understand what it means, but I have actually probably maybe 10 patients like this right now in my practice. The decision I've made is to follow them a little bit closer than otherwise I will tell them you don't have MDS, don't come back here anymore. There is also another story that I find fundamental, and we're going to have some data presented hopefully attached this year, where it appears that a fraction of patients with therapy-related myelodysplastic syndrome, they may have antecedent mutations. This sometimes people refer to as clonal hematopoiesis, before they got the chemotherapy for the primary malignancy. So this was first published by the group at WashU. So they look at group of patients that had lymphoma and they had developed later MDS AML. And they were able to track blood from these patients before they were treated with any chemo radiation therapy for the lymphoma. And they found, using very sensitive techniques, a p53 mutated clone that then expanded, I guess, later with the chemotherapy for the lymphoma, particularly stem cell transplantation. So we've looked at this data, hopefully it will be presented attached, and it's difficult to track these patients. This is almost doing like archaeology, because our banks don't keep these samples, but we have 13 patients like this, and half of them actually you can see the mutation before you treat them for lymphoma. So this has very important implications, because we've never talked, for instance, about prevention, and we don't really understand what is the frequency of this. But if this is true, that half of your patients with lymphoma that go on to develop MDS, AML, have these kind of mutations before, maybe you will follow these people differently. But we don't know truly what is the denominator of this phenomenon. So I think this is kind of like risky time, because in one hand you like to have all this information, but imagine you are the patient and now I'm telling you that, well, you don't have MDS, but you have the TET2 mutation, or you need therapy for lymphoma, but you have a very small clone with p53, and maybe this one day will give you secondary neoplasm that is unfortunately lethal right now. So that is story that is, I think, very, very interesting, and it's telling you that this disease is really evolved over a long period of time. So that's number one. And then, how these patterns of mutations dictate what type of therapy or not. Unfortunately, in MDS, most of these mutations don't really drive the disease, like TET2. I don't think, this is a driver of the disease. We talked during my lecture, I think, in terms of second acquisitions like FLT3, RAS. I think those second drivers that lead transformation, I think you had very similar data at some point also in MPNs going to AML. That's a different aspect of this disease that may have a very interesting therapeutic target. But the reality, everybody is doing this kind of assays, more sophisticated, less sophisticated, more genes, less genes. But even private practice, this is universally done, and I'm not sure we really 100% understand what this means.
But biologically, it's a fascinating story. The novelty that we have at our disposal is amazing. We are at the rapid pace of learning, and you're right, we don't really know how to use this clinically, but we will eventually understand it better and apply it in our everyday practice.
Actually, you're totally right. I think what's going to happen is not going to be the mutation. I think what you're going to see is where does this mutation happen, because what this allows, and I think now we look at this as scientific, research test, but this actually should not be complicated to do in practice. You could track these cellular compartments where this happens, and you could, the ways, I think there was a little bit on tools for assess response, or these criteria are in a way naive. What is a CR is silly. I mean, you do this and there's MRD or there's a mutation. I think soon we're going to be tracking this disease, and you're going to say you have 10% of the cells that have this particular mutation and the others, and you're going to see how this population shift. And maybe there are people that have some of these mutations like IDH. I have people in remission, maybe they don't mean anything. Maybe they are in a very primitive clone, and this clone may take 20 years before it gives you the disease back, and others may evolve very fast. So I think what is going to be very interesting and what is going to really help us is actually to see the cellular compartments that carry this, and how your therapy, just say JAK2 inhibitor, inhibits these populations, and maybe make very nice clinical predictions in terms of response. I think that's going to be very interesting.
And in MPN, we are a little bit behind, I would say, behind the MDS in research and understanding what is happening, but it seems that this is following the same path.
Yeah.
We learn about the driver mutations, so-called driver mutations that activate the JAK-STAT pathway, the JAK2 mutation, calreticulin and MPL mutations in classic Philadelphia chromosome negative MPN. But now we are gathering together, all together of us, all these mutations that also happen in epigenetic control, spliciosom mutations, and they have tremendous influence on what actually happens with the patients, not
Right.
just in the presence, but in order of acquisition.
Right.
And this is at the time of a disease happening, as well as the time of disease progression. We had 2 different talks on this topic.
Or in responding to treatment.
You're right, only in response to
So,
therapy. That's
yeah.
Exactly true.
Yeah.
Less of that effect on the response to therapy appears to be the case in MDS, where you look at what happens with the patients with hypomethylation agents, and we had a talk on CMML as well. We are limited in a number of therapeutic approaches, and in some cases, perhaps with JAK2 inhibitor, number of mutations matter, but with hypomethylation agents, that appears to be less relevant. But we are looking beyond that with new targeted agents, like you said. Now, there was also a number of clinically relevant discussions. One was by Dr. Komrocky about the integration of this information in the prognostication of the patients and perhaps intervention earlier on, and the same applies for MPN, which we'll tackle later, with transplant options, because that's the only curative potential, and again, our armamentarium of the medications is very limited. What is your view of such an attempt to integrate everything we know biologically with clinical characteristics?
Yeah, so we're also in a little bit of transition, but this to me, because I started doing this maybe seriously, like thinking about this disease, let's say 6-7 years ago. And you know, when I started thinking about this disease in our program, you know, we worked together, the decision was, is this patient transfusion dependent? Yes, no. And then independent, go home, I'll see him back in 6 months. Now we're significantly more sophisticated than that. Now this is true, I mean, that was the decision. Is he getting transfusions? Yes, okay, we treat. And we gave induction chemotherapy in those days, even to low risk MDS. Now this is significantly more sophisticated, and the pendulum is going that way. So a few years ago I looked into this because when I started seeing a lot of patients with myelodysplastic syndrome, I saw that there were patients with low risk disease by standard criteria, that they were doing very poorly. And I would look at them like, why is this so we developed this model that now has been basically validated by anybody, very simple model. And it's true, and I bet you probably the same thing in MPNs, that you can identify a fraction of these patients that look totally normal by blast, chromosomes, but actually they have a very poor evolution of the disease, so they get sick fast from the disease. Right now, your point is very well taken. You don't offer transplant because the transplant is too toxic. You know, you have 20-30% mortality. In someone, you know, with low risk MDS, in general, they can live 5-6 years not intervention. So if we knew how to actually identify these people, we will benefit. First of all, we will exclude patients that don't need transplant, and then we could focus on those that need transplantation. So there are a couple of things happening. This molecular data is being generated by multiple programs. So at ASH, there's going to be a big presentation by international consortium that we are part also, where we're trying to integrate IPSS type of a schema with this mutational architecture. I think that's going to be the next level, where, you know, if you look at IPSS and IPSSR now, the cytogenetics probably are much more important than the percentage of blasts. That is traditionally what we looked at. And I think this molecular data may allow us actually to even detail this even more in the context of a specific cytogenetic alterations. And then once this data is there, that this should be basically anytime soon, then you could really start doing very nice studies saying, okay, can we do what Dr. Verstovsek is saying, is that in a group of patients that are at very at higher risk of evolving, transforming, or dying from MDS, could you then do an intervention either from hypomethylating agent or a new phase 1 clinical trial or a stem cell transplantation early on, and do what basically all oncologists do, that is either, you know, secondary prevention or early intervention, not just let the disease go. So I think this is going to be very, very important, but it needs to be prospectively studied. I don't think we can assume 100% that because you have a bad mutation and you have this disease even in an earlier stage, that something like transplant is going to overcome this poor prognosis, because one of the most important presentations was not actually discussed today by Dr. Cutler, and actually I thought he was going to discuss this, is, for instance, this issue that if you have a P53 mutation and you go for transplant with MDS, outcome is not very good. So it's not 100% that you have a bad feature and you're going to do well with the most aggressive therapy. Sometimes that is a bad feature for any therapy. But this molecular data, to finish, is going to change how we prognosticate these patients. These IPSS, IPSS are going to be replaced by a molecular version of these studies. And the fact that you can sample this from peripheral blood, for instance, you are going to be able to actually predict from very early on what the course of the disease is going to be. It's going to be very interesting.
And the clinical parameters will still be important because,
Absolutely.
for example, these normal individuals with clonal hematopoiesis, you certainly are not going to transplant them to correct that abnormality. So it's going to be a good, interesting mix.
That's right. And so in MPN, Dr. Sharma gave us a nice summary of mutations and which to test for when and why. I think she did a really nice job here. But we also learned through 2 talks on biology and a clinical management of a transformation of MPN to acute myeloid leukemia, which appears to be really a huge area of unmet need. Perhaps 20-25% of patients with MPN transform, and the average survival is only a few months. Now we know much more through this genetic testing, epigenetic testing, about events leading to transformation, acquisition of P53, and we have some sense what to do, at least from a limited number of attempts in the laboratory, to understand that by using different medications. Like there was a nice discussion by Dr. Mascarenhas about hypomethylation agents, JAK2 inhibitors, and other novel therapies in combinations for this particular group of patients. You see this as a way of future to trying to understand, because on the other hand, in the biology section, we had learned that there are multiple pathways to acute myeloid leukemia. It's not all the same.
Right. No, absolutely. I think, you can get overwhelmed very quickly with the complexity of all of it. I would say that, one particularly important part, particularly when you're evaluating a new patient, is just for diagnosis. So now we have so many more tools, especially with the identification of calreticulin, in actually putting a molecular marker and actually calling a clonal molecular abnormality associated with myeloproliferative neoplasms in the vast majority of patients. An interesting conversation about the so-called triple negative myelofibrosis, which seems to act very poorly, and I would argue is really myelodysplastic syndrome. I don't know if you have an opinion on that one.
So this is the one that doesn't have any of the
that
three.
That has myelofibrosis without calreticulin mutation, without JAK2 V617F, and without a MPL mutation identified. That particular subgroup tends to do very, very poorly.
Yes, and that was really brought up as a problem, but it also gave us a chance to really utilize the molecular testing.
Right.
And there are some other epigenetic abnormalities that appears to be detrimental in MPN that guide us, and Dr. Vikas Gupta was talking about that, to perhaps intervene with a transplant early on in myelofibrosis, which is still debatable.
Right.
We really don't know how to use that information, but we are getting there, like in myelodysplastic syndrome, with early intervention if you have bad genetics, right, or epigenetics.
Yeah, no, absolutely. I think ASXL1, if you're leaning towards transplant but unsure, an ASXL1 mutation might push you over the edge. But I think this one's difficult. I think that's really hard.
That's why I think Dr. Gupta gave us a more realistic approach.
Yeah.
We have a JAK inhibitors, we have a transplant, how to combine them together.
Right.
And it seems that there is a good way to improve the condition of the patients with a short course of a JAK inhibitor, followed by the transplant. And that brings the even better survival after the transplant, surprising to me. But it does make sense.
Yeah.
You improve the condition of the patient. Now in MDS, you mentioned we had a presentation on a transplant with a surprising twist. The question was posed at the beginning, how to prepare the patient with MDS to benefit from the transplant the best. Which type of cytoreductive therapy, because we usually think in that line, and then it seems that there are some patients that would require no therapy before the transplant. Where is the field going?
Oh, this is very, very controversial, and I have some issues with, and it's not just from Dr. Cutler. Actually, our group at MD Anderson has published some similar data. So traditionally in AML, you've always kind of the bulk patients. The norm has been you want 10% blast or 5% blast, etc. And this is because transplanting people with active disease associated with very high rate of relapse. And actually what is very fascinating is that this still applies. Nobody that I know of will transplant someone with AML with active disease outside the context of refractory relapse disease, where actually there are some trials looking at. But what Corey was mentioning is that it appears that there are some patients that have good outcomes without any quote-unquote pre-transplant type of therapy, either hypomethylating agent or intensive chemotherapy. I've looked at some of this data in quite a bit of detail, and I think this is talking about a very small percentage of patients highly selected. I think that extrapolating that you don't need any type of therapy before transplant will be a mistake, because my experience is that unfortunately in myelodysplastic syndrome, as opposed to in acute myelogenous leukemia, there is a very, very high rate of relapse post-transplant. And it goes back to, I think, what I was talking about earlier. What is the compartment that is affected by this disease? I think that MDS in general is a more primitive disease than AML, may happen in different compartments. And I think it's very difficult to eradicate this altered stem cell. And then what I see in my practice is that these patients that, we work very hard to take them to transplant because I want to take them to transplant, that younger patients with good donors, etc. I can tell you that there's a very significant rate of relapse. And then sometimes these relapses happen actually with very aggressive molecular features, and they're very difficult to control. So in my opinion, the conversation, and I say that with all respects to transplant doctors, it should not be like this. This conversation of one therapy versus therapy, this is naive. This is really not realistic. I think these are people that they see one aspect of the disease. I see this disease longitudinally for many years, sometimes from very low-risk disease to when they die from acute myelogenous leukemia. So the question is not should you transplant or not. The question is how do you integrate transplant. It's basically, I missed this talk on the JAK2 and the transplant, but that's where we have to go through. That is, what is the best timing? How type of peri-transplant type of therapy? And again, this is for MDS. What type of post-transplant maintenance therapy you do? They have a JAK2 mutation, is there a role for that? They have a TET2 mutation, they have FLT3, whatever it is, but can you adapt your therapy? What is the role of these hypomethylating agents post-transplant? Because it's an illusion that these patients are cured with transplant, and it's an illusion actually that transplant by itself will do it. It does it in highly selected patients that they are able to report. In your general practice with continuous flow of patients, outcomes in MDS with transplant, I don't know how they are in myelofibrosis, they are poor, and there is a very high rate of relapse. So I think we need to go back to, I like this theme of the myeloma doctors. I think they are ahead of us. I mean, how do you do total therapy? And then really define not one versus the others, like how do you do this together? And I think it's very critical, particularly in diseases like MDS, that the median age is 72, 73 years of age. To really figure out who's the best candidate, what is the best source, etc. So there are many issues around this that make this concept, I think, complex. I don't know how it is in myelofibrosis.
Well, I think many of the same issues. I think transplant is effective where essentially no other therapy is for advanced myelofibrosis. So I think it's a real and very powerful tool. I think, like you were saying about P53, and transplant for MDS, the hard part is the highest risk patients are the ones that you're more inclined to refer for transplant, but those are the patients who actually tend to have the highest transplant-related mortality and have the highest risk of relapse. And so we're always facing that. It's not a contradiction, but you know what I mean.
Yeah.
This is a really nice discussion. Let's move to some more easier waters. You gave us a wonderful talk on the masked PV, talking about the continuum in the follow-up of the patients. ET, PV, myelofibrosis, as the three groups doesn't appear to be black and white, like 1, 2, 3.
Right.
We have masked PV,
Right.
PV in progression. How we define it? What is it? What do we do about it?
So I think this is a really tough one. I think it's the concept of masked PV is the idea that perhaps clinical pathologic features of polycythemia vera are pretty well defined, and there are patients who don't have the perfect hemoglobin hematocrit to actually meet criteria, but they phenocopy true polycythemia vera, or they might even have a worse prognosis. I think that it does become very difficult. There ends up being a lot of overlap, in my opinion, between masked PV and some of our other disorders, and I think really it does become a bit semantic on the one hand, and also probably speaks to the idea that polycythemia vera diagnostic criteria are a little bit too specific and perhaps could be broadened to circumvent this issue. But I think if you have somebody who appears to have polycythemia vera that doesn't actually meet criteria and they meet masked polycythemia vera criteria, you would be wise to treat them as though they have polycythemia vera.
So we need to sharpen our diagnostic tools or diagnostic criteria.
Yes.
We also need to improve our prognostication. We're also learning about these mutations
Yep.
at a slower pace because there are not too many of those, but some of the driver mutations appear to affect the thrombosis risk in some patients more than the others.
Yep.
In ET in particular, we had a very nice talks on the prognostication, on therapeutic approach, and on diagnostic, like you said, masked PV. And then the issue of new therapies. We have long-acting interferons, we have JAK inhibitors for PV now, perhaps in the future for ET. Looks like we are moving slowly, because this is more benign condition, toward really getting more options for the patients in a need. People usually say it's benign, not necessary, but there are patients always. Is it 10%, is it 20%? There are patients that need help. Looks like this is good new development for us to have these two other options now.
Yeah, absolutely. And I would say a big theme of the conference was active participation in clinical trials. I think it's the same in myelodysplastic syndrome is critical. But absolutely, I would agree with that.
So I thank you very much for your participation. It was a great discussion, and I hope you enjoyed the discussion and that you will participate online. This is expert opinion on the U.S. focus on myeloproliferative neoplasm and myelodysplastic syndrome. Thank you very much for joining us. Until the next time, goodbye.